Welcome to eCrit Care Podcast. Hi, my name is Swapnil, and today I'm joined by my guest, Dr. Ary Serpa Neto from Austin in Melbourne. So, Ary, welcome to the show.
Thank you very much. It's really a pleasure for me. Thanks for the invitation, Swapnil. It's a pleasure to participate.
Now, you have a very diverse career in intensive care medicine, and you worked across different continents. Can you please tell us a bit more about your background and your interest in research?
Yeah, of course. So I did my medical training in São Paulo, Brazil. I was born and raised and bred in São Paulo. It's a very large city in Brazil, 25 million people, 12 million people in the metropolitan area. So I did my med school, my internal medicine training, and my ICU training back in São Paulo, Brazil. Then I did a master's in health sciences under a program called MD-MSc. While I was doing my internship, I was also doing a master's in health science, and I received my master in 2010. And then I started working in research in Brazil, mainly focused on mechanical ventilation. I had my first PhD there in the University of São Paulo, investigating the impact of lung protective or protective strategies of ventilation in patients without ARDS. And then I started to collaborate with a very strong group in Europe called Proof Network. We created this group in 2012, did it together with Professor Marcus Schultz from Amsterdam, the Netherlands, with Professor Paolo Pelosi from Genoa in Italy. Unfortunately, he passed away in 2021. And with Marcelo Gama de Abreu, a professor from Dresden in Germany, who is now in the US. So we started this network, and then we started to do a lot of trials in ventilation, especially in theater and also in the ICU. So we led a lot of landmark trials like the PREVENT trial investigating the use of tidal volumes in patients without ARDS. We did the PROBEASE trial, the PEEP level in obese patients during surgery. We did the PROTOR trial, the PEEP levels in patients undergoing one lung ventilation. We recently finished the ACTIVE trial, investigating the use of automated ventilation in patients in the ICU. We did RELAX. We did a lot of trials. And together with that, I did my second PhD with Marcus there, where I received a PhD cum laude in intensive care from the University of Amsterdam. So this was my first part when I worked and I was also working as a consultant in Brazil at the time and also doing a lot of research with this European group. Then in 2019, I applied for a grant to come to Australia and with Rationale. I came to Australia for a month here in Melbourne, and then at the end of 2023, I received my fellowship, and then since then, I'm working as a consultant at the Austin, and since last year, due to unfortunate passing of Professor Rinaldo, I assumed as the Director of Intensive Care Research at the Austin, and as the co-deputy director at the NZRC at Monash.
Yeah, I thought doing one PhD is crazy enough. Doing two PhD, I don't know what to call that.
I always receive that. Yes, true. Yeah.
So after doing my PhD, I was like, no more research. But amazing career, and congratulations. And I think obviously it's big shoes to fill after Professor Bellomo passed away to head the same department where he started all the research activities. So well done and congratulations.
Thank you very much.
So today we are going to dive deeper into the trial that I'm very fortunate to be part of, called as GuARDS trial. Now, this is a very interesting trial, and I think being the principal investigator, it will be really good to hear directly from you about what's the hypothesis, what we are trying to really evaluate here, and then later in the part of the podcast, we'll dive deeper into behind the scene, some of the challenges part. So just to start with, tell us about what's this GuARD trial about and what's the hypothesis.
Yeah, great. So GuARDS stands for glucocorticoids in patients with acute respiratory distress syndrome, or ARDS. The hypothesis is very simple. The hypothesis is that the use of dexamethasone in patients with moderate to severe ARDS reduces 60-day mortality. So it's a very simple hypothesis, and I don't know if you want me to dive into already on the rationale, but I think it's like this is a question that we have like at least 20 years of discussions about the use of steroids in patients with ARDS. So GuARDS comes exactly to answer that question, and I think will be, if things go as we are expecting, will be the first well-powered study to address that question.
Yeah, the steroid in ARDS is a little bit of yo-yo story, when it started and it kind of died down and the COVID came and suddenly it kind of rejuvenated the whole debate around the steroid, and remap cap came, and then we really saw that difference especially with the dexamethasone. And I think that's probably another kind of interesting question, why particular steroid, choice of steroid in GuARDS, why you chose dexamethasone over hydrocortisone or methylprednisolone, any particular rationale there?
No, I think honestly the rationale was that the first trial that showed a potential benefit in patients with ARDS, which was the DEXA ARDS from Jesus Villar from Spain, was published in 2019, so it was before the pandemic. The trial used dexamethasone. The reason is like, if you review the whole literature, like most of the trials used methylpred. And I think this was because they were heavily influenced by the work of Meduri back like 20, 25 years with different trials investigating post-therapy, 1 milligram per kilo, different doses, and it was always methylpred. We have a joke in Brazil that we say that methylpred is the preferred drug for respiratory physicians or pulmonologists, like we say in Brazil, and this is probably this is the reason that why they use methylpred. Of course, with all the things that we know, the different properties of methylpred compared with hydrochloride and other drugs. But I think the dexamethasone came because Jesus based his trial on a Dutch trial that investigated the use of steroids in patients with community-acquired pneumonia. This, again, as I said, this is back in 2015, 2016. This Dutch trial was published in The Lancet, suggested some benefit with dexamethasone in patients with community-acquired pneumonia. Then Jesus and the team used this trial as a, let's say, a starting point for the DEXA ARDS. And because the trial used dexamethasone, they kept dexamethasone. They just increased the dose, considering that patients with ARDS, they are sicker than patients with community-acquired pneumonia. The inflammation is greater than in patients with pneumonia, so they increased the dose. And that trial, despite being like, the trial was interrupted earlier due to slow recruitment, but it showed like a very impressive effect of dexamethasone with like increasing the number of ventilator-free days at day 28, reduction in duration of ventilation, reduction in mortality. Of course, hypothesis generating because it was less than 300 patients were randomized. It was a small trial, but definitely showed a potential benefit of steroids. Then COVID came, and I think with recovery also using dexamethasone and showing benefit in patients with COVID, I think the community accepted that dexamethasone was the best drug to test. And I think the COVID was a very important thing for us because this is a personal opinion. We have some evidence to support, but I think all trials, steroids trials in ARDS, they always pointed towards a potential benefit of steroids, but they always had issues, and mainly related to sample size, early stopping, problems with recruitment, heterogeneity of population, and because it's difficult to do a trial in ARDS. We all know it's very difficult. And then COVID came, and of course, recovery was done in a population that was not necessarily ventilated. But we all know that a lot of these patients had ARDS, but they had ARDS for a single disease, which was COVID. And in recovery, we were able to they were able to randomize thousands of patients, and they were able to show a benefit. And I think discussing with different colleagues, they were just saying, this is exactly what we think will happen in ARDS. If we are able to randomize this amount of patients, we will probably be able to show the degree of benefit that was suggested in some of the previous and smaller trials, but that we were not powered to show. So I think it started with this community-acquired. Jesus published the DEXA ARDS suggesting a strong benefit. Then recovery came, showed like a strong benefit in a population that a lot of patients had ARDS. And then I think the community basically said we need to do a proper trial to address these questions like once for all and understand if this is beneficial or not for our patients.
Yeah, thanks, Ary. And that's interesting because with ARDS, after the Berlin definition, there has been still a bit of controversy about does really ARDS exist, and is it basically syndrome at constellation of different pathologies with a different pathophysiology? And even with the COVID, we kind of saw that it's not one phenotype is same to other phenotypes. So I guess with regards to having one drug fits or solves the problem for entire syndrome, what's the kind of underlying rationale and where does benefit come from?
Yeah, I think I agree 100% with you, and we can discuss this phenotype point, I think, later. But just going back to your question about the rationale, I think the whole rationale is that we start simple and we can be a bit more complex. So ARDS is an inflammatory disease. We all know, especially in the early phases. And steroids, they are anti-inflammatory drugs. They have anti-inflammatory-like effects through genomic and non-genomic actions. So the basic rationale is that we have inflammation, we use an anti-inflammatory drug, we reduce the pulmonary and the systemic inflammation, and this potentially improves the outcome of the patient. But also we have like data suggesting that steroids, through these effects, they can also, for example, reduce the pulmonary leak and restore the endothelial or the alveolar capillary barrier and reduce the pulmonary leak. It can promote resolution of lung injury. It can also limit the fiber proliferation that we know it's the consequence of ARDS after some days, acknowledging that we have data suggesting that late steroids are not beneficial, they are even probably harmful, but steroids can limit the fiber proliferation and reduce the risk of fibrosis. And we have studies investigating like type 3 procollagen as a marker of fibrosis, showing that steroids can reduce that and also can reduce the biotrauma. That we know that ARDS is associated with biotrauma, which is the release of inflammatory markers and distal organ injury, and steroids can also reduce that. So I think we have like a very strong rationale for the use of steroids in this population. But I agree with you that under the umbrella of ARDS, we have patients with viral disease, we have patients with bacterial disease, we have patients with smoke injury and inhalation injury, we have patients with trauma, and it's hard to understand or to believe that steroids will work exactly the same for all these patients. So this is why I think we need a large trial, acknowledging the limitations of enrolling patients with a syndrome and not with a disease, which is the difference from COVID. And this is the same for sepsis, I think. But we also have the possibility, and this is something that we are planning to do in Australia, but they are doing in the UK, of collecting blood samples at randomization of these patients. And then in the future, use this data to understand if there is heterogeneity of treatment effect based on different phenotypes, including hyperinflammatory, hypoinflammatory phenotypes like described by Caroline Calfee, or even other other phenotypes based on different biomarkers. So I think we are starting like as a big trial with a very heterogeneous population based on the data that we have that suggests a potential benefit. But the idea is to refine using these biological markers to see if there is a specific phenotype that benefit more from steroids than another.
Thanks, Ary. So the next segue is into how did you come with this sample size calculation, knowing that ARDS mortality has traditionally been 50% over the period of like last maybe 60 years. So how did you come with this sample size calculation in this particular trial?
Yeah, good questions. I think we need first to describe or to discuss that GuARDS is a different ARDS trial. And I always make this joke with some colleagues here, and you know this very well. Every time we talk about ARDS trials in Australia, everyone's like, no, it's impossible. We don't want to do, because thank God in Australia, ARDS is it's rare. I think it is low. Of course, I think we have a degree of underdiagnosis because it happens everywhere, but it is low. So the first thing is that GuARDS considers an expanded criteria, which is very aligned with the last global definition published years ago. So we are not including only patients with traditional ARDS. So traditional ARDS by the Berlin criteria was like intubated patients with bilateral diffuse infiltrates with some degree of hypoxemia. So this is a traditional criteria. We are of course including these patients if they have a PF ratio below 200, but we are also including other patients. So we are using an expanded criteria where we also include patients who are extubated, receiving non-invasive ventilatory support. So if you have a patient and using non-invasive ventilation through a face mask or a helmet, whatever it is, this patient is potentially eligible. And if you have a patient using high-flow nasal cannula, they're also potentially eligible, assuming that they have a flow of at least 30 liters per minute, and they have a PF ratio below 200. So this is very aligned with the global definition, where a new criteria was created called non-intubated ARDS. So I think this is the first thing to consider. We have the traditional, but we also have patients on high flow, and we also have patients on non-invasive, providing they have some specific criteria. Then, because of that, the mortality dilutes a bit, and it's expected to be a bit lower than the traditional ARDS that we know it's up to 50%, and in some countries like even higher. So the assumed mortality for GuARDS was 40% in the control arm, and this was based in the very recent systematic review published by some colleagues from the UK, where they retrieved a lot of trials and studies in ARDS, and this is like the expected mortality if we also consider this expanded definition. So 40% was the starting point of the mortality in the control arm. Then to calculate the sample size, we need to estimate the effect size. So by how much we think that mortality will be reduced with the use of steroids. Initially, of course, the trial that was used was Dexamethasone, the Spanish trial, because it is the best evidence that we have using the same drug and the same dose. The absolute risk reduction in that trial was almost 15%, 14%, which we think it's unrealistic. Of course, it's a trial that was stopped early, so it can be a random high with overestimation of treatment effect. And then we assumed a more conservative effect, half of the size of that, which is 7 to 8%. Again, acknowledging that this is high. We understand that it'll be impressive if we find an intervention able to have an absolute risk reduction of 80% in mortality. Like, I think I can only remember of the ProSiva trial, which is, I truly believe the findings, but I don't believe the effect size. I think it's less than what was reported there. But you know that, like, sample size calculation is always, and now I'm taking my doctor hat and putting my research hat. It's always a very difficult thing to do, because if we want to do a perfect trial, it's unrealistic. We'll end up with because for people who are listening, like, the sample size has a direct relationship with the effect estimate. So if you consider a very small effect size, you need a lot of patients. So, for example, if you say we think realistically it will reduce 3% the mortality, and it's very relevant. So you need a trial of 10,000, 15,000 patients. So when your effect size is really small, you need a lot of patients to show that effect. So at the end, we always have to play a bit with what is realistic and what is feasible from a recruitment perspective, a funding perspective, and then knowing that 8% is high, but it is what is realistic. And even with 80%, we end up with almost 1,500 patients, which is a lot for an ARDS trial. And then finally, the trial is expected to have 2 interim analyses and 1 final analysis. So because we use this group sequential design, every time we look at data, we are penalized from a statistical perspective. So we have to recalculate the sample size and inflate the sample size, because we are doing these looks before the end. And inflating the sample size and considering some loss to follow-up expected to be around 3%, we ended up with a sample size close to 1,500 patients in total, running in the UK and in Australia. So 1,500 is the total sample size. Acknowledging that we might end up with some effect that is not as large as 80%, then we won't be statistically significant and the trial will be underpowered. It is what it is. We know if we powered for 3%, which is relevant, we will need 10,000 patients, 15,000 patients, and it's very difficult.
Yeah, and I completely acknowledging the challenges nowadays, especially with the funding agencies being very stringent with the research criteria. People are very quick to criticize about underpowered trial or why should I not adopt the result of the trial. But I guess getting up to the trial can be quite interesting journey. And I guess I just wanted to get your thoughts on how your journey so far about GuARDS getting off the ground and getting the funding, and what are the challenges, and why just Australia, UK, and why not, I guess, Brazil, where you come from, and Europe, for example.
Yeah, it's a very good question. So Manu Shankar Hari is the CI, or the global principal investigator of this trial. And they started in the UK and they received grant to run the trial in the UK, but they know that it will be impossible for them to randomize 1,500 patients in the UK. And they also know, and we all know, that having like a broader representation from other countries is always good. So they reached out to us and said, look, what are you interested? And then we said, of course we are. We just need to have funding to support the sites here. So what we did, we started to apply for different grants. So we started with ICTC, which is an international cohort and trials collaboration with the MRFF. We applied 2 years ago and we were unsuccessful. As usual, until you are successful with a grant, you apply several times. So we were unsuccessful. And then we applied again for an MRFF CTA, clinical trials activity, and we were successful. So it was pretty good. We were successful in our second application, and then we received funding to support the trial in Australia. And the main issue, I think, is research is an expensive thing to do. And we know that the hours of our research coordinators, it's really important. They are very important, and their hours are really something that we need to support. And the system is under a lot of pressure at the moment, especially in New Zealand is also bad, but in Australia too. And we know that we have hospitals losing research coordinator time, research manager time. Most of the units, they don't have research coordinators funded by the unit. They are all funded by trials. So means that the per patient payment is what fund their salaries. So when you write a grant, you have to consider the per patient payment, and this needs to be a very good per patient payment to support the sites and to keep research running. Because we know it's not only about GuARDS, it's about securing the jobs for other trials too. So what is a realistic like per patient payment in Australia today? I would say that at least $1,000. And it depends of the complexity of the trial. So if it's a prior consent trial, if it's a waiver of consent, if it's an opt-out. So it depends the burden of the data collection, the burden of the intervention, they all of course increase the per patient payment. So you can always come with a number and say, look, let's write the grant to enroll 1,000 patients and pay $100. And then it's unrealistic. It's not competitive with the number of trials that we have, and it's unrealistic. You're not paying you're not paying like even like I think a third or a fourth of a research coordinator time. So this is something that is really important for me every time I write my grants, and I try to secure a lot of the budget for research coordination, and even things like that we usually like that cost like database creation and things like that. I put at the lower minimum because I can do it at no cost. And then I can save more money for the research coordinators and for the sites. Because Swapnil, it's not our job, or my job as a PI of the trial is very easy. It's difficult as the CI at the Austin. And I play both sides, and I know that my job as the PI for GuARDS is very easy. I have Mairead and Fiona. They are amazing project managers and project officers. They do a lot of their work. But when I'm running the research program at the Austin, this is the difficult part. Because you have a lot of trials that you need to recruit, you have to approach the patients in a difficult time, you have to consent the patients, you have to deliver the intervention, you have to follow the adherence, you have to collect the data, you have to protect the research coordinators. So I always say that this is the most important part, and these people need to be acknowledged and recognized, not only the PI of the study. So, and this is why for example, in GuARDS, we had to say we will randomize 250, a max of 300 patients in Australia, because otherwise the funding will be impossible, and we will not pay what we truly believe that the research coordinators deserve. So I know that at the end, if the trial is underpowered, it will be criticized because of that, and I know that what we expect from the community to criticize trials, I criticize trials when they come. It's important to do, but acknowledging that we cannot be perfect most of the time, because like funding is an issue, structure is an issue, number of patients that we have in Australia is also an issue. So this is why definitely we want to have Europe involved, we want to have Brazil involved, but it's all limited by the ability of these places to first raise funds and second, recruit the patients. For example, Brazil is a very difficult place because it's the funding is very limited. Because it's a low middle income country, the funding for research is very limited. We don't have a very strong national council or agency like we have the NHMRC in Australia, the NIH in the US. We don't have. So funding is mainly from a specific government program, which is restricted to the 5 big hospitals in Brazil because it's just a tax exemption. It's not like we have in Australia. So we have 5 big hospitals in Brazil. They are private hospitals, but they are academic hospitals. And as part of their tax exemption, they can have tax exemption if they use this money to support education and research. And then you can raise like millions of reais and millions of dollars, but it's restricted to 5 hospitals in a country of more than 230 million people. So that's one of the reasons that is why it's very difficult to do this trial in Brazil. In Europe, they have more funding like opportunities. Like for example, in the Netherlands, we have a very good agency called Zoom, which is the agency, the national agency that we use for most of our trials. So it's all about raising the money and collaborating. But we are very in favor of collaborating and having more people involved. The funding that we have in Australia, for example, we cannot send money overseas. So it's different from the NHMRC CTCS, for example, where you can support trials, or you can support sites in different countries. With the MRFF CTA, we cannot. So it's only Australia. So all these things at the end limit our ability to recruit more patients, enroll more sites, and enroll different countries.
Yeah, thanks, Ary. I think there's a lot to unpack there. And I think for people who are probably going to start their research career, it can be quite scary. And I think the grant is one of those things that unless you have first grant, you can't get a big grant.
Yeah.
So it's like a bit of vicious cycle there. So it's really tricky for someone who is starting their research career journey. But I guess with your background, I think you've done amazing to secure the funding. And as you said, even in a second attempt, which is pretty great.
Yeah.
Obviously, it's not a blinded trial, and I guess doing the blinding has got a lot of challenges. Do you think that will have any kind of particular impact on the trial results, or do you think just like COVID or any other dexamethasone in ARDS trials in the past, it shouldn't have huge implications?
Look, I think it's always a limitation. It's always a limitation not having a blinded trial, especially a drug trial. It's always a limitation, but you can reduce the impact of that limitation. So I think having a very crude and strong and easy primary outcome, like mortality, reduces the limitations or the problems with having an open label trial, because mortality is a yes or no outcome. A patient died, a patient did not die. It's different if you have like a subjective outcome that could be subject to bias and being influenced by the lack of blinding. So I think it is a limitation. It will be highlighted as a limitation. It will always be criticized, but we need to reduce the impact of that limitation, and having a strong primary outcome is a way. But I think like ideally, yes, we should do like a blinded trial. The problems are, so you can blind in two different ways. This trial, you can blind using like a central company to develop the placebo, which is very expensive. And then again, it will add something to the budget and will reduce the amount of money that you have to support the sites. And then it will probably impact the sample size, but you can have like a central blinding using like a company specialized to create that, or you can blind in the site. I think like if you ask me, like if we started this trial in Australia, I will try to do it blind, like we did Soda-Big, for example. You have like two investigators. You have what we call an unblinded investigator. This unblinded investigator will randomize the patient and prepare the drug, which can be a saline syringe or can be a dexamethasone syringe, deliver this drug to the bedside nurse, and the bedside nurse will deliver it blinded. So this is possible, but consider that it is a treatment for 10 days. So 5 days at 20 milligrams, 5 days at 10 milligrams, or until ICU discharge. So if you have a patient who stays 10 days in the treatment, you need a research coordinator or an unblinded investigator every day preparing the drug or the placebo. And then you end up having people during the weekend, for example, to prepare the drug. It's feasible. Yes, it's possible. It's feasible, but it's difficult because you need someone preparing. It's different from Soda-Big, which was a 5 hours infusion. And then we just needed this unblinded investigator to prepare the drug, one bag, deliver the bag, and that's it. So I think it's possible. It's hard to do without central blinding from a company, but it is a limitation. But I think at the end, it's always nice to see, because I don't know, just pushing to my other trial, the Soda-Big trial, we did a blinded trial, but we were criticized by the community because was it truly blinded? You said, because if you do an ABG, you can see if the pH is increasing, if the base excess increases. So at the end, you were like unmasking, which is true, but not 100% true, because you have patients who could just improve without any sodium bicarbonate. And it's the same as having like a beta blocker trial, which is blinded or not blinded. If you're measuring the heart rate, you can potentially unmask the treatment allocation. But it's still, Darren Teichman, one of the editors of the New England, during this discussion in Belfast, he came to me and to Paul Young after the discussion and said, look, Ary, I understand all the limitations of blinding sodium bicarbonate, the blood gas, but it still is a very good thing about the trial, and this is why we accepted it in the New England, because it's better to have that than not having anything like the bicar ICU. So I think, yeah, it would be better to have a blinded trial, but I think it was not feasible at the time. But I think like it is a limitation. But the use of mortality as the primary outcome limits a bit that impact.
And you chose the 20 milligram for 5 days and 10 milligram after for 5 days. Any particular reason you come up with this particular dose? What was the kind of rationale of that dose?
Yeah, so that dose was used in Dexa-ARDS by Jesus Villar, the trial that I mentioned that showed potential benefit. And the dose was based on the Dutch trial. So they had this Dutch trial showing. Remember that this was back in 2014, 2015. So we did not have the Cape Cod trial at the time showing potential benefit with hydrochloride 50 QID or 200 milligrams for patients with community-acquired pneumonia, which was from France, published recently. This was like 10 years ago. There was this Dutch trial suggesting some benefit in patients with community-acquired pneumonia. And then after discussion with the community in Spain, Jesus came with this, like, we need to use a higher dose. I need to be honest, it was an arbitrary decision. And if you read the paper, the Dexa-ARDS, it's not very clear how they came up with the 20 and 10. They tried to justify it based on this Dutch trial and a sicker population, increase the dose, but there was no big rationale, so it's a bit arbitrary. But once Dexa-ARDS was published and showed a potential benefit, the dose was selected because of that. And acknowledging that if you review all trials investigating steroids in patients with ARDS, as I said, you have a huge heterogeneity in the drug, like methylpred, hydrocort, dexamethasone, huge variability in the dose, 1 milligram per kilo post-therapy lowered. So there's a huge variability. So it's just like, we have, let's say, I don't want you to reduce the Jesus trial to a pilot trial, but let's say we have a very good pilot trial, close to 300 patients. Let's try to progress this pilot to a larger phase 3 using the same strategy who potentially showed some benefit.
Thanks, Ary. So how's the kind of overall recruitment going, and what's the kind of expected finish line for this trial?
Yeah, so we are recruiting better than expected, I think. And I think the main thing is like having this expanded criteria increase a lot the chance of recruiting patients. So we have 16 patients randomized now in Australia. We started 1st of April, so let's say 4 months. We are recruiting really well in these sites. We have 1, 2, 3, 4 sites who are truly 4 sites that randomized 1 patient, 5 sites active. So it's going better than expected. The overall feedback, and of course you can comment because you are also participating in recruiting, and thank you very much for your help. But I think the feedback from the research coordinators, at least at the Austin and other hospitals that we discussed, is usually very positive, because if you have the patient, the randomization is simple and the delivery of the intervention is very simple. You just put an order for a dexamethasone following the trial, or a usual care, which is no dexamethasone, but is still allowed to have up to 200 milligrams of hydrocort equivalent in the usual care arm. And I think this is a positive thing, because it allows for the use of 50 QID for shock, or even 50 QID for community-acquired pneumonia. And then you just approach the family or the patient for a brochure, which is a consent form that we are using, and you collect the data. So the feedback's been positive, and I think the simplicity of the trial with a good per patient payment, as we discussed like before, and especially if you consider the complexity of the trial, I'm confident that we will be able to recruit well. And I think the fact that we are using this expanded criteria is really important. And I just for example, in parallel, I remember discussing this with Rinaldo. We are doing a pharma trial called ESCAPE, which is investigating trimodulin in patients with severe community-acquired pneumonia. And by severe community-acquired pneumonia, I mean like a community-acquired pneumonia intubated and with a high CRP. And they designed this study, and they said, we need to randomize patients within 24 hours of ventilation. They started with 12 hours, and we said, look, it's impossible. It's impossible, especially for a pharma trial where you need prior consent. So 12 hours is nothing. So they expanded to 24 hours. And I remember Rinaldo saying all the time, you need to consider patients who are extubated and receiving non-invasive ventilation or high flow, because we changed our practice. I understand that intubated patients, of course, we select a sicker population and we have some degree of prognostic enrichment, but it reduces a lot our capacity to recruit, because we changed our practice. We are using high flow in these patients all the time. We are using non-invasive all the time. So I think, and they're struggling a lot with recruitment in ESCAPE because of that. And I think for GuARDS, having this expanded criteria is a very good thing. And this is why I'm confident that we'll be able to recruit very well in Australia. Of course, because of our community and our research coordinator and investigators, the CTG, we are very good already. But I think with this expanded criteria, will be even better.
Yeah, and I think the personal experience just using the RateCap database and randomization software is very simple, easy to use, and it's actually quite amazing. So really well-designed trial. I guess the key thing with the ARD is because there's so many treatment options come into play, especially proning and ECMO. They're the two main kind of competing kind of priorities, especially we've seen the difference with proning. Do you think that will impact the recruitment to some extent? Because obviously some centers are pretty pro ECMO centers, and then will that have any impact on the trial recruitment?
Look, it's not an exclusion criteria. If you have a patient on ECMO, you can still recruit the patient. We understand that, of course, if you put a patient on ECMO, you can improve the PF ratio, and this patient will not be eligible based on the threshold of 200, which depends on the severity of the patient. If they are really sick, even on ECMO, we know that the PF ratio is still below. But I don't see any limitation or any issue related to ECMO or proning, acknowledging that this can improve the PF ratio and reduce the number of patients that are eligible. But in my experience, like even when you use ECMO prone in this very sick population, the PF ratio is not necessarily above 200, so they will still be eligible. I think the main issue for ECMO will be if the sites they have equipoise for giving the dose of steroid. A lot of sites says it's a high dose of steroid. For some sites, it's not usual. I would say, for example, that in my site in Brazil, it is the opposite, because a lot of RESP physicians, and we have all the strong community of Marcelo Amato that you all know about, the lung protective ventilation, driving pressure, and they really love steroids there. And they use a lot of steroids, methylpred, even before this trial. So it's different. My feeling is different from a lot of Australian centers where we don't use a lot of high-dose steroids. So I think it would be more a matter of equipoise if you have or not. But I don't think ECMO prone will reduce a lot the number of patients eligible for the trial.
Yeah, fascinating. So I guess obviously your interim analysis will be happening somewhere towards
25% of recruitment. I probably will say a number here that is not 100% right, but I think global recruitment is probably close to 400 or 500 patients. So we have it's running well in the UK too. So yeah, the 25% will come very early, very soon. Sorry, and it will be the first interim analysis. Yes.
Yes, thanks, Ary. I think once again, congratulations on a very well-designed trial, and I'm looking forward to another NEGM publication. So yeah, just keep smashing.
No, thank you very much for helping us with this study. First thing, it's really great to have you on board. Thanks for inviting me. Always open to come and discuss. Always very nice to participate.
Thank you.
Okay.